everyone, now we are on chapter 17, blood. You may remember from Biology 263, A&P 1, that blood is actually a connective tissue, and it has a fluid matrix. So we say that blood is a fluid connective tissue. The plasma is the non-living fluid matrix that surrounds the formed elements or cells. The formed elements are erythrocytes or red blood cells, leukocytes, which are the white blood cells, and there's actually several subtypes of white blood cells, which we'll be talking about, and platelets, which are also referred to as thrombocytes, although a platelet is actually just a fragment of a large cell that had burst into little pieces, and that's the way platelets circulate within the blood. So here is a figure that represents the major components of whole blood, and figure 17.1, and it illustrates how you can withdraw blood from a vein, which is very superficial. I'm sure you've all had this done at some point in your life. The blood is withdrawn and put into a tube, and this tube actually goes into a centrifuge. And when you centrifuge material such as blood, the heavier components will go down to the bottom. And so this shows you how blood can be separated when you have the erythrocytes, the red blood cells, go down to the bottom. They are the heaviest. And then you have the buffy coat, which is a really light colored material, and it's consisting of white blood cells or leukocytes and platelets. This is actually less than 1% of whole blood, and you can see down here it describes that of the entire blood in this tube, the erythrocytes compose about 45% of whole blood generally, and this is the most dense. This is why it goes to the bottom. This yellowish color up here is the plasma. Plasma comprises about 55% of whole blood. It's the least dense component, and that's why it stays toward the top after centrifugation. So blood is sticky, it's opaque, and of course it's fluid, and it definitely has a metallic smell or taste to it. You may have noticed if you bit your tongue at some time or had blood, bleeding gums or whatever, it does have somewhat of a metallic taste. And of course, there is a metal associated with blood, and that's the iron in your red blood cells. The color is slightly different when there's a high oxygen content. This will be a scarlet color. And then when there's a lower oxygen content, such as the venous blood returning from the body back to the heart, this is a darker red color. The pH needs to be kept within a very narrow range. It is slightly alkaline, 7.35 to 7.45. If the pH goes far beyond either one of these, if it becomes too acidic or too basic, it can be a threat to life. Blood also composes about 8% of body weight. The average volume is about 5 to 6 liters in males and 4 to 5 liters in females. So, what is the function of blood? One of the major functions is that it distributes substances throughout the body. It also has a way to regulate the blood levels of substances that are circulating in the body. And it also has functions of protection, and we'll talk about each of these. So the distribution functions include delivering oxygen, gas, O2, and nutrients to the cells. It also transports metabolic wastes from the metabolizing cells to the lungs and to the kidneys for elimination. Blood also transports hormones throughout the body. Regulation functions. These include maintaining body temperature, maintaining a normal pH, and also maintaining circulatory system fluid volume. So it somewhat regulates itself and body temperature. The protection functions include preventing blood loss. So within blood itself, there are plasma proteins and platelets that will lead to clot. Another word for clot is thrombus formation that will stop the bleeding if there's some kind of a severed blood vessel, or for some other reason there's bleeding out from the circulatory system. It also prevents infection. So within the blood, there are antibodies. I talked about those earlier from chapter 21 in the immune system. And of course, we call antibodies a gamma globulin. There's a variety of them, and there's also that protein complement system. Also, white blood cells or leukocytes. These are these are the cells that are responsible for preventing infection. So what is plasma? Blood plasma is about 90% water, but there's over 100 types of dissolved solutes within the plasma. There's also suspended particles, and there is a table in the next slide, and this summarizes what we will find within blood. And this is particularly the blood plasma. Table 17.1. 90% of the plasma volume is water. And water is essential, of course, for dissolving and suspending solutes in the blood. Water also absorbs heat. Earlier in the semester in A&P 1, we reviewed the properties of water, which is also talked about in the Fundamentals of Biology class. And so water is the universal solvent for living organisms. Solutes, electrolytes. When you hear the word electrolyte, that's referring to some kind of a charged particle. Electrolytes are the most abundant solutes by number would be electrolytes. The cations include sodium, Na+, potassium, K+, calcium, that's a Ca with 2 pluses, then you have magnesium as well. Anions include chloride ion, phosphate ions, and a phosphate is actually a group of atoms together, but there is a negative charge, sulfate and bicarbonate. These are also groups of atoms. Together they have a negative charge, so therefore we can say they are anions, negatively charged. These electrolytes or ions help to maintain the plasma osmotic pressure and normal blood pH. Then there's also plasma proteins. Plasma proteins form about 8% by weight of the plasma, and all of these contribute to osmotic pressure and maintain the water balance in the blood and the tissues. So by having plasma proteins, particularly the albumin, this will actually serve to keep the water within the circulatory system so that the water doesn't seep out into the tissues. So there's other types of plasma proteins that serve as transport proteins, enzymes, etc. Of the plasma proteins, one of the major ones is albumin. This is actually 60% of the plasma proteins. It's produced by the liver, and this is the main contributor of osmotic pressure. Globulins, we talked about those before. These are globular proteins. They are actually forming about 36% of plasma proteins. You have alpha and beta. These globulins are produced by the liver, and most are transport proteins that bind to lipids, metal ions, and fat-soluble vitamins. The gamma globulins, this is the one we actually talked about. These are your antibodies produced by your plasma B cells during the immune response. Then there's a protein called fibrinogen. Fibrinogen is a soluble protein. It forms about 4% of the plasma proteins. It's also produced by the liver, and when it gets the signal, if there's a bleeding in the body and there needs to be clot formation, this fibrinogen will go to the site where there's the breach, or if there's bleeding of a blood vessel, and this will be converted into fibrin, which is insoluble, and these fibrin threads will form part of that blood clot. Then we have non-protein nitrogenous substances. These are the byproducts of cellular metabolism. You will be hearing these more about these later: urea, uric acid, creatinine, and ammonium salts. Then there are nutrients, organic nutrients. These are materials that are absorbed from the digestive tract and transported throughout the body to be used by the cells. They include glucose, other simple carbohydrates, amino acids, which of course are protein digestion products, fatty acids, glycerol, and triglycerides. These triglycerides, of course, are fat digestion products. Cholesterol and vitamins. We absorb these from the digestive tract into the bloodstream. So the blood will be carrying this to the cells where needed. Also, respiratory gases, oxygen and carbon dioxide. Oxygen is mostly bound to the hemoglobin. This is a big molecule that is inside red blood cells. Carbon dioxide is primarily transported and dissolved as bicarbonate. Some of it is just transported as CO2, and there is some portion that's also traveling in the blood bound to hemoglobin. Hormones, steroid-based and also protein-based hormones will travel in the bloodstream. Steroid and thyroid hormones are carried by plasma proteins in the blood, though. Okay, this is a little bit of a close-up to albumin. Again, it's 60% of plasma protein. What does it do? It is a substance carrier, it's a blood buffer, and it also serves to maintain osmotic pressure in the bloodstream, plasma osmotic pressure. Of the formed elements, only the white blood cells actually are complete. The red blood cells, they still look like a cell. There's a cell membrane, but just before the red blood cells go out to circulate in the bloodstream, they spit out their nuclei. So all blood cells are formed in the bone marrow, and so right when the red blood cells, or erythrocytes, before they go out into the bloodstream, they just spit out their nucleus, and then they become these little biconcave discs. We'll be looking at those more in a little bit. Platelets are actually just fragments. Most, of course, will originate in the bone marrow, and as they circulate, they can be damaged, worn out, so the formed elements all must be regularly replaced, being made primarily in the red bone marrow. And here is a photomicrograph of a human blood smear that's actually been stained with right stain. So keep in mind, in the body, these do not look purple. They will be, they're hard to see. So that's why we use stain, of course, with prepared slides, so that structures that accept that stain will be more visible. Now, the erythrocytes, or red blood cells, they actually are just packed with this pigment called hemoglobin. There's iron in these hemoglobin molecules that causes this pigment to actually look red or pink. And so these little red blood cells, they kind of look like donuts here. They're not. There's no hole in the middle, but they're very thin. Again, they're biconcave. You'll see that in a minute. And so they actually just show up with no stain. They don't pick up stain, because the structure that really picks up stain would be the nucleus of a cell. And these cells do not have their nucleus anymore. Now, white blood cells over here, you can see there is a variety, and we'll be talking about each type of white blood cell pretty soon. This is called a monocyte. This always kind of reminds me of a Pac-Man, like a little mouth here, so you can remember M. Lymphocyte, these are neutrophils. Neutrophils are a very common white blood cell circulating in the bloodstream, and they have a very irregularly shaped nucleus. Over here, these little purple fragments, these are platelets. They originated with one big, huge cell, and that cell bursts into a bunch of little pieces, and each little piece has some of the nucleus, so it looks this dark, it picks up the stain. Okay, what is an erythrocyte? Erythrocyte, of course, is a red blood cell. Erythro means red. So they are biconcave discs. They don't have a nucleus. They are larger than some capillaries, so therefore, being biconcave, they can fold up and squeeze through these little tiny capillaries. They're filled with this complex protein called hemoglobin, often abbreviated H, capital H, lowercase b. They have this other protein called spectrin, which actually helps give the shape flexibility. Red blood cells are the cells that give blood its viscosity. Viscosity means thick. You'll be hearing this word quite often. Viscous is thick. Okay, and here's a picture. Picture is worth 1,000 words. You can see this red blood cell from the side. It's really tiny, 2.5 micrometers. This is the side cut. And then from the top, it will look like, actually, as you remember in that photomicrograph, this is so thin in the middle that it didn't even show up very well. But from the top, it looks like that. So also that red blood cell's biconcave shape increases the surface area to volume ratio. Surface area is incredibly important in the body in many, many ways. This red blood cell is also packed with hemoglobin. It's more than 97% hemoglobin. There are no mitochondria, so therefore they don't metabolize with oxygen. So, what is the erythrocyte's function? Respiratory gas transport. Hemoglobin, here's another way to abbreviate hemoglobin, HGB. Hemoglobin binds reversibly with oxygen. That means the oxygen can bind to it when oxygen is in a high level in the blood, and then when oxygen is in a low level, when the oxygen is going out from the bloodstream to go into the metabolizing cells, the oxygen will come off the hemoglobin. Normally, males, for erythrocytes, there's 13 to 18 grams per 100 milliliters, which is also called a deciliter. You may have heard that. Females, it's 12 to 16 grams per 100 milliliters. So what is hemoglobin? Hemoglobin is composed of a globin portion. Globin is a globular shape, and this is a protein. And this protein is pretty complicated. There are 4 polypeptide chains involved. 2 are called alpha chains, and there's 2 beta chains. Then there is a heme portion. This is the pigment that's bonded to each globin chain. Within each heme group, there is a central iron atom, and it's the iron that binds with one molecule of oxygen. Each hemoglobin molecule, because there's 4 of these polypeptide chains, therefore it binds 4 oxygen molecules. In each red blood cell, there are about 250 hemoglobin molecules. So there's lots and lots of oxygen that can be bound. In the lungs, this is where we see oxygen loading, because the oxygen will diffuse from the air into the bloodstream at the site of the lungs. And this produces what is called oxyhemoglobin. That's when the oxygen binds to the hemoglobin. Then you get oxygen unloading at the tissue level or the cellular level. And this is when the oxygen comes off of the hemoglobin molecules to get into the metabolizing cells that are taking in glucose and oxygen in order to get energy. This is going to produce a darker red color, deoxyhemoglobin. And that we also say that that's reduced hemoglobin. CO2, carbon dioxide loading, happens at the level of the tissues. because remember, in living cells they take in glucose and oxygen and give off H2O, water, and CO2, carbon dioxide, as the waste products. So at the level of the tissues, about 20% of that carbon dioxide in the blood will bind to hemoglobin, although the majority of hemoglobin is transported in the blood in other ways, which we will come to later. But of that CO2 that binds to hemoglobin, that will now be termed a carbaminohemoglobin. We like to use a lot of compound words here. And here is the picture, actually not a picture, but it's a drawing, a figure of the structure of hemoglobin. And they've actually been able to get images as tiny as proteins. And so scientists are learning more and more every day about the structure of proteins. Hemoglobin is a large protein, and you can see here in the brownish color, you've got the beta globin chains illustrated, and they're all folded up, and then these more beige color, you've got the alpha globin chains. Each one of these has a heme pigment associated with it, the red disc with the green ball in the middle, and you can see each hemoglobin molecule has 4 of these heme groups because there's 4 polypeptide chains. And a close-up of this iron-containing heme pigment, you can see Fe, of course, is the atomic symbol for iron. And there is nitrogen, the element nitrogen is here, hydrogens, carbon. So it's a complex molecule in itself, but the point is that it binds to iron, and iron will bind oxygen gas. That's where the oxygen is carried within the hemoglobin, within the red blood cells. Hematopoiesis. This is a word that means blood cell formation, and it happens in the red bone marrow, within the marrow spaces. This is actually a little bit also in the reticular connective tissue and the blood sinusoids within the red bone marrow. In the adult, this is found in the axial skeleton, in the girdles, pectoral girdle and the pelvic girdle, and the proximal epiphyses of the humerus and the femur. Remember, proximal is the one nearest the core of the body. So in these epiphyses of the humerus and the femur, and then within the axial skeleton and the pectoral and pelvic girdle bones. In those bones in the red bone marrow is where blood cells are formed. Now, hematopoiesis actually occurs within, it actually starts out with hematopoietic stem cells. A different term for these would be hemocytoblasts. These are stem cells that produce all of the various formed elements. So the stem cell can go in different directions to form different types of blood cells. So the hormones, various hormones and growth factors can direct the differentiation toward various pathways. Like, for example, in order to produce red blood cells, it goes in one direction. To produce white blood cells and the various types of white blood cells, it will go in a different direction. And then to form platelets, it will go in yet a different direction. And there's a figure coming up that illustrates this. Once the cell is down the pathway, it's committed. So it would have to stay in that pathway. That means it can't change back to become a different kind of a cell. Then, once formed, these new cells enter the sinusoids in the bone marrow, and then they will leave out to a sinusoid. Remember, is an enlarged blood vessel, so it will go out into circulation. This is kind of a nice illustration that shows the formation of red blood cells. So here we start out with the hematopoietic stem cell. This is a hemocytoblast, and it could go in different directions. This way for white blood cells, the other way for platelets, for example. But this is how the red blood cells are formed, and that is called erythropoiesis. because this is red blood cell formation. So it starts out becoming a pro-erythroblast. Now it's committed, and it has to go down the direction to become a red blood cell. So it goes through various developmental pathway phases, and you don't have to memorize each one of these, but we have various things going on. Ribosome synthesis when it's a basophilic erythroblast. Then you've got a polychromic erythroblast. And then here's your orthochromic erythroblast. And this is the point where it just spits out the nucleus. It's ejecting the nucleus, and then it becomes a reticulocyte, and then finally we see the fully formed erythrocyte, that biconcave disc that is going to be circulating within general circulation in the circulatory system. Regulation of erythropoiesis. If there are too few red blood cells, the individual will experience hypoxia. This means a lack of oxygen to the cells. If there's too many red blood cells, it will increase the blood viscosity. It will be too thick and it won't circulate very well. It could lead to a stroke or clot formation, so that is not good either. So the regulation of erythropoiesis is very important. You want to have just enough red blood cells to be able to have the optimum delivery of oxygen to the tissues. So the body makes more than 2 million red blood cells per second. The production and destruction of worn out blood cells is affected by hormonal controls, and available iron in the body, amino acids, and B vitamins. So let's talk about the hormonal control. There's a particular hormone, and it's called erythropoietin. It's shortened EPO. EPO, sometimes they call it EPO. Erythropoietin is the hormone that increases erythropoiesis. There's always a small amount in the blood, and what happens is if you have an increase in red blood cells or an increase in oxygen levels, this will inhibit or depress the production of more red blood cells. Erythropoietin is released, believe it or not, by the kidneys in response to hypoxia. Hypoxia is when you have a decrease in red blood cells due to hemorrhage or an increased destruction of red blood cells. Or you have a decrease of hemoglobin per red blood cell. Example, someone who may be experiencing iron deficiency. Either they're not taking in enough iron in the diet, or their bodies are not absorbing that iron from the digestive tract into the bloodstream. Or you might even see hypoxia if you go up into high altitude. If a person goes up into the mountains where there's a lower barometric pressure, oxygen is harder to obtain up at high altitude. So going up in high altitudes decreases the oxygen availability in the air. So if you have an increased levels of erythropoietin, this is going to lead to a rapid maturation of those committed cells. You'll have an increased circulating reticulocyte count. If you remember, this was the cell that was right before that biconcave disc, the actual mature erythrocyte. So a reticulocyte is an immature red blood cell, and so when you're seeing more an increase in erythropoiesis, you'll also see a higher reticulocyte count. Now, athletes may take erythropoiesis exogenously. That means that this can actually be injected, and it would have to be ordered by a doctor. And so too much of this erythropoiesis can be dangerous. You can imagine why an athlete might want to give themselves more erythropoietin. Think about it. If you have more erythropoietin, that leads to more red blood cells. That leads to more oxygen carrying capability in the blood. But giving erythropoietin erythropoietin to a person is actually very dangerous because it can lead to too many red blood cells, therefore increased blood viscosity. Also, testosterone, that hormone, that sex hormone testosterone, that is the predominant hormone in males, the predominant sex hormone in males, this will increase erythropoietin production as well. So this is showing the teeter-totter figure, which generally represents maintenance of homeostasis, which we talked about during A&P1. Here is this is representing normal blood oxygen levels when it's in balance. Now, when it goes down, this imbalance is representing hypoxia, a low level of oxygen delivery. Inadequate O2 delivery due to various reasons, either decreased red blood cell count, a decreased amount of hemoglobin, or a decreased availability of oxygen gas. Therefore, it will target the kidney. And realizing that tissues in the kidney actually produce erythropoietin didn't happen for many, many years. Physicians wondered why individuals that had kidney failure were becoming anemic. And then they realized that indeed certain tissues in the kidney produce this hormone. So from the kidney and also the liver to a smaller extent, we get the production and release of this hormone, erythropoietin. Erythropoietin, as other hormones, travels in the bloodstream, and it will go to the red bone marrow to stimulate red blood cell production. Enhanced erythropoiesis increases red blood cell count. Therefore, we have the O2 carrying ability of the blood goes back up again to maintain a balance. Now, if you have too much of this erythropoiesis, and the imbalance could go up the other way, too many red blood cells. But this is how the body normally reacts to keep the red blood cell count in balance. So what do we need for the body to make red blood cells? Erythropoiesis. It's forming the red blood cells. You need to have protein. A good protein source in the diet allows the essential amino acids in order to make the hemoglobin molecule. You need lipids, the proper lipids, carbohydrates, vitamin B12. This is the B vitamin that's required for the body to be able to produce red blood cells, and also folic acid. Also, you need to have iron in the diet. If any one of these is severely lacking, the red blood cells will not be able to be formed properly. So with iron, you get that primarily from the diet, but the body can also store some of that. But once the stores are depleted, then it needs to come from the diet. Iron is also available from degraded red blood cells. Remember, red blood cells are constantly being worn out, and they need to be broken down. But when they're broken down in the body, the iron can be recycled. It'll be stored in the liver, the spleen, and the bone marrow. And you may have heard about, a couple generations ago, I think, like my grandma used to talk about having some liver and onions. People would eat beef liver as a source for iron. But there's other things stored in the liver as well. So, free iron ions are actually toxic. So in the body, iron ions are stored as ferritin and hemosiderin, and this is transported by a protein called transferrin. The ferra comes from the symbol for iron, Fe. Erythrocytes, they last and they function in the body about 100 to 120 days. There's not going to be protein synthesis or anything. Those cells, once they're worn out, they're broken down, and in the meantime, new cells will be being produced. Old red blood cells are fragile. And remember, these little circulating erythrocytes are biconcave discs. They have to fold up and bend up in various ways to get through the tiny capillaries. So they're subject to a lot of potential damage and stress to them. So they don't last forever. But the old red blood cells become fragile and the hemoglobin actually degenerates. And these red blood cells will be trapped, especially in the spleen. Macrophages here will engulf the dying red blood cells in the spleen, that is. And then what happens is the heme and the globin parts are separated. The iron will be salvaged. The heme, that pigment portion, if you remember, it looked like that red disc with the little green iron atom in the middle. This heme portion is going to be degraded to what we call bilirubin. And then the bilirubin, it goes to the liver. During circulation, the liver then secretes the bilirubin, most of this bilirubin, into the bile, which then is secreted into the intestines, into the small intestine as bile. What happens in the intestinal tract, the bilirubin will be converted to urobilinogen, and then this urobilinogen, as it travels through the large intestine, it will be converted into stercobilin by bacteria there. It's actually a brown pigment, and that is why feces look brown normally. Then what happens to the globin? Remember, the globin is a protein, so it's broken down into amino acids, which can then go into general circulation, and these amino acids can be used by the body in order to make new protein where needed. Now this is showing, this figure is kind of small, but it shows the life cycle of red blood cells. 1. Low oxygen levels in the blood stimulate the kidneys to produce erythropoietin. Erythropoietin levels rise in the bloodstream. Erythropoietin and the necessary raw materials in the blood promote erythropoiesis in the red bone marrow. New erythrocytes enter the bloodstream. They function about 120 days. Then the aged and damaged red blood cells are engulfed by macrophages in the spleen, the liver, and the bone marrow, and the hemoglobin is broken down. Here you see the heme part, and this is the globin part. Of course, the globin is broken into amino acids, and they can go into the bloodstream and be delivered to other cells as those cells need to make their new proteins. The heme, okay, what happens is the iron part, this will be stored as ferritin or hemosiderin in the liver, and then the bilirubin is picked up by the liver as well, and this is going to be secreted into the intestine and the bile, where it's metabolized to stercobilin by bacteria, and then the stercobilin is excreted in the feces. And here, number 6, it's saying that the raw materials are made available in the blood for erythrocyte synthesis. So we're kind of going through this cycle. The food nutrients such as amino acids, iron, B12, and folic acid are absorbed from the intestines and enter the blood. So this is showing kind of a close-up where low oxygen levels stimulate the kidneys to make erythropoietin. Erythropoietin levels rise. Erythropoietin and raw materials promote erythropoiesis in the red bone marrow, etc. And this is showing how the erythrocytes circulate. And then this is the last half of that figure, where you have your aged and damaged red blood cells engulfed by macrophages in the spleen, etc. And you've got the hemoglobin broken down, and then this heme part has to be further metabolized. Bilirubin is a yellow pigment. Some of the bilirubin actually is changed by the liver into a form that is water soluble, goes back into the bloodstream, and then it can be excreted by the kidneys. Did you ever wonder why urine is yellow? It is due to a pigment, a metabolite from the breakdown of bilirubin. Now most of the bilirubin, though, is going to be turned into bile, stored in the gallbladder, and bile is actually necessary for fat digestion. So it's really pretty amazing. If you have little kids, they might ask you, why is poop brown and why is urine, or whatever they call it, pee-pee, yellow? And it has to do with this pigment bilirubin. Now, if you shut down the system and bilirubin level rises in the bloodstream, that's where an individual can become jaundiced. And jaundice is a yellow color pigment that will be deposited under the skin. In dark-skinned individuals, you may not be able to see it, but you would be able to see it in the sclera, or the whites of the eyes. And that would show up there. That's indicating potential liver failure. And in infants, because their livers are so immature, the enzymes are not active yet, and if they have a high load of bilirubin, they can become jaundiced as well. And if they have a high blood level of bilirubin, it can actually damage the brain. So that needs to be watched very carefully, the bilirubin level in newborns. Okay, so this is actually the bottom part of that figure, which we went over already. Erythrocyte disorders, anemia. Anemia is the term for abnormally low oxygen carrying capacity. It's a sign rather than a disease itself. So there could be several potential causes for, or one of several different types of causes for anemia. The O2 levels in the body cannot support normal metabolism. The person will experience fatigue, pallor, that means they'll be very pale, shortness of breath, and chills. And there's actually 3 major groups of types of causes for anemia. One, most obvious one, blood loss. If a person's losing blood, they will be most likely have anemia, depending on how quickly the blood is lost. Or they could have low red blood cell production or high red blood cell destruction. So with blood loss, okay, blood loss can be due to either an acute hemorrhagic anemia, rapid blood loss. So somebody's losing a lot of blood, you need to replace that blood. Not only the blood for the volume, but also so that that blood will have enough red blood cells in it to be able to deliver oxygen to the tissues. There's another type of blood loss, we call it chronic. If it's a chronic hemorrhagic anemia, that means that they have slight but persistent blood loss. This may happen if someone is bleeding in the intestinal tract and they test the stool or the feces for the presence of blood, or they look it looks like a blackish color. That could be due to blood loss, very slow but chronic over a long period of time. In order to treat that, you need to find out what's causing this chronic blood loss. Another way that a person could become anemic is with low red blood cell production. Iron deficiency. If you're not getting enough iron or absorbing enough iron in the diet, you can become anemic. So the cause of hemorrhagic anemia, well, actually, if you have some hemorrhagic anemia, you'll also have iron deficiency anemia. So if you have a decreased iron intake or absorption. I'm not sure why hemorrhagic anemia is there. But anyway, the evidence for this type of anemia would be microcytic, or very small red blood cells. When they examine the blood on a microscope slide, they will notice that the red blood cells are too small. The treatment to increase iron intake or absorption. So it's not just taking more iron. If you're taking a lot of iron in the diet, but it's not being absorbed into the bloodstream, it's not going to correct the situation. Anemia caused by low red blood cell production. Another cause, all right, so the first one is the iron inadequate intake or absorption of iron. This one is called pernicious anemia. Pernicious anemia is an autoimmune disease. It actually destroys the stomach mucosa. We also see this with chronic alcoholism. If someone is drinking alcoholic beverages every day and not taking in enough nutrients, particularly, it's actually very hard on their stomach, and they are not able to produce the intrinsic factor. This is produced in the stomach's lining. So, but there's also an autoimmune disease that particularly causes this. It's called pernicious anemia. So regardless of the cause, whether it's alcoholism or the autoimmune disease, when this intrinsic factor is not made by the stomach, the person cannot absorb vitamin B12. Now, the red blood cells on the microscope will look very large because the red blood cells can't divide. What is the treatment? They would actually be given vitamin B12 per injection or a nasal gel, because remember, giving it to them orally is not going to do any good because the stomach lining is not normal. This is very rarely due to low vitamin B12 intake. In the diet, it's not hard to find vitamin B12. There's another cause of low red blood cell production, and that's renal anemia. Remember, I mentioned that when doctors realized that individuals who had kidney failure were becoming anemic, that's when they discovered that the kidneys make erythropoietin. So if a person has renal disease, they won't be producing enough erythropoietin, and therefore they will have low red blood cell production. Treatment would be synthetic erythropoietin delivered per injection. Another cause for low red blood cell production is aplastic anemia. This is when the bone marrow, the red bone marrow, is destroyed or for some reason inhibited. This could be due to drugs or toxins, chemicals, radiation, and certain kinds of viruses. Usually the cause is unknown, but all cell lines are affected, so they will also have abnormal levels of white blood cells and platelets, actually low levels. The treatment would be transfusions and like a bone marrow transplant with the stem cells. Okay, anemias due to high red blood cell destruction. Hemolytic anemias. This is where you get premature red blood cell lysis, meaning they just burst. They just are damaged. They have to figure out why this is happening. One of the causes could be a hemoglobin abnormality. Another cause would be an incompatible blood transfusion. This would be very obvious right away. If there's an incompatible blood transfusion, it will begin to lyse or destroy the red blood cells. So you obviously know as you're giving a blood transfusion, if there's an issue with that, you stop the blood transfusion. Also, certain infections can cause this. Now, the ones that are due to high red blood cell destruction, the very first category of those that there's an abnormally early destruction of the red blood cells, it could be due to thalassemia. Thalassemia occurs among individuals from the areas around the Mediterranean Sea, where a globin chain is either absent or faulty. The red blood cells are thin and delicate, and you get a decreased level of hemoglobin. The severity ranges from mild to severe. The most common cause for high red blood cell destruction, when it has to do with, and this is a genetic problem, would be sickle cell anemia. This is when there is in the they call it hemoglobin S. So this is when one amino acid is wrong, is just the wrong one in the beta chain, both of the beta chains. And now they call that hemoglobin S for sickle cell. The red blood cells will become crescent shaped when there's a decreased oxygen. When the person is under stress, when they get sick or whatever, and there's decreased oxygen, these red blood cells just pop into this crescent shaped structure, which can get, they can actually get blocked. They can block small blood vessels. They get trapped because their shape is very brittle. The red blood cells rupture easily, blocking small blood vessels. Now, usually the sickle cell anemia due to a gene that's inherited would be from someone with African ancestry, typically Africa around where the equator is. Because when you think about it, in the equatorial region, it remains warm to hot in the weather all year round. And so you've got mosquitoes that are endemic. That means they're, actually the mosquitoes are just very a large population of mosquitoes, and malaria is the disease that's called endemic because the mosquitoes are not killed off by the winter cold. So malaria is a disease that kills about 1 million people a year in these regions because of the survival of the mosquitoes year round. Mosquitoes spreads malaria all year round, and we call this area of the earth the malarial belt, right around the equator, because it's so warm throughout the year. If a person inherits one sickle cell gene, this actually led to malaria resistance. If you have one copy, we call this the sickle cell trait. So individuals who ended up inheriting one gene copy for the sickle cell gene, some of their red blood cells would become sickle-shaped, and it releases potassium that actually kills the malaria parasite, the parasite that causes malaria. And so therefore they had a survival advantage over individuals that had 0 copies of this gene. So with one copy of the sickle cell gene, that we say that they have the sickle cell trait, and that's what leads to a survival advantage for malaria if you're infected with malaria. However, if 2 individuals come together and have a baby where that baby inherits 2 copies of the sickle cell gene, this is what's going to cause sickle cell anemia. So sickle cell anemia, it's actually a disease where they will be relatively okay for most of the time, but they can go into crises. An acute crisis is when many of their cells become sickle-shaped due to a drop in oxygen in the blood. And so if a person's having an acute crisis, they will have a lot of pain in the joints. There can be a lot of pain in the spleen. The spleen will often be really enlarged. So what happens is they can get a transfusion. They can inhale nitric oxide, which is abbreviated NO. It's actually a vasodilator, so that can help. And so they often will go into the hospital and be treated in this way. Prevention would be taking a drug known as hydroxyurea. This actually increases fetal hemoglobin, so therefore there would be less chance that they would have those sickling cells with the S hemoglobin in them. Stem cell transplants, and now they're even looking at gene therapy. And this is showing a normal red blood cell, or normal erythrocyte. And here, these are the amino acids making up this beta chain, one of the polypeptide chains in the hemoglobin. There would be every single hemoglobin molecule has this abnormality. This number 6 is supposed to be this particular amino acid, but this one is substituted with the sickle cell. It's the sickled erythrocyte that results from a single amino acid change in the beta chain of the hemoglobin. And so the red blood cell, when oxygen level goes down, it becomes sickle-shaped. Other kinds of erythrocyte disorders include polycythemia vera. This would be bone marrow cancer, caused by bone marrow cancer, and it's an excess red blood cell production. It's a type of red blood, or bone marrow cancer, excuse me. There's also secondary polycythemia. This is when you go someone goes to high altitude, their body will start to make a lot more of the erythropoietin, leading to a higher red blood cell count, or blood doping. Blood doping is, as I mentioned earlier, if an athlete is going to compete, they may want to have a higher level of oxygen in their blood so that they can run faster and ride their bike faster, jump higher, whatever it is. More oxygen gives you an advantage with physical competition events. So, but if they're going to inject erythropoietin, they are putting themselves at risk for polycythemia. Leukocytes. Now we're on white blood cells, or leukocytes. These make up less than 1% of the total blood volume. Normally we have 4,800 to 10,800 white blood cells per microliter of blood. These defend against disease. They have this ability to engage in a diapedesis. This was discussed earlier in chapter 20. We talked about the immune system in chapter 21. They're somewhat amoeboid in shape. They have little extensions that stick out, and they can actually squeeze through the capillaries. They also respond to chemotaxis. That would be chemicals at the site of an infection that actually draws them toward that area so that they can deal with the pathogen and clean up the area. Leukocytosis is actually when the white blood count is greater than 11,000 per microliter. So these are too many white blood cells. It may indicate an infection. Leukopenia is the opposite. This is when the white blood cell count is less than 4,000 per microliter. So there's actually two major categories of leukocytes. There are granulocytes. These are cells that have little granules in them, and there's three kinds. Cytoplasmic granules means these granules are in the cytoplasm. Neutrophils, eosinophils, and basophils. So there's three types of granulocytes. Then there are two other types of white blood cells that are called agranulocytes. A means without. So these have no granules. And the two kinds of agranulocytes are lymphocytes and monocytes. I actually learned this sentence in order to help me remember the names of the types of white blood cells in order of how commonly they are found in circulating in the blood. Never let monkeys eat bananas. Neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Basophils are very rare in the blood, circulating in the blood. If they are higher, it could indicate some kind of abnormality. And here is a visual representation of that. Here's your formed elements: erythrocytes, leukocytes, or white blood cells, and platelets. When we say someone is having a CBC, that's complete blood count. When we see if you hear in the medical field CBC with diff, that's referring to a complete blood count with differential. And that means they're not only counting the amount of erythrocytes, leukocytes, and platelets, but they're also counting the different kinds of white blood cells. So again, there are different kinds of white blood cells. Normally, granulocytes, neutrophils, eosinophils, and basophils are found in these proportions. The most plentiful white blood cell would be the neutrophil, generally forming 50 to 70% of the total count of your white blood cells. Eosinophils and basophils, very small amount of that proportion normally. Agranulocytes, lymphocytes, and monocytes are the agranulocytes. The lymphocytes are the second most common. So if you look at these percentages, that should conform with never let monkeys eat bananas. You've got neutrophils, so we're going to actually be looking at blood smears in the lab. So most likely you're going to see some neutrophils. You will most likely see some lymphocytes. We very rarely actually see any eosinophils or basophils. So we'll be doing this in lab, and it's kind of fun to see what your own blood looks like. You'll do a blood smear and we'll stain it so you can see the blood cells. Granulocytes, Granulocytes, these have these cytoplasmic granules that will stain with right stain. All the granulocytes are phagocytic. The most numerous, neutrophils. We also call these polymorphonucleocytes, because the nucleus has means many, it's very unusually shaped. It's a lot of lobules, like you will see it when you look at the cell. It's a real unusual and large nucleus. For short, these are called polys. So if you hear them refer to polys when they're analyzing the blood, it's referring to these neutrophils. The granules stain in a lilac color. It's a very light colors. These cells are very phagocytic. The next type of granulocyte would be your eosinophils. Eosin is a red color stain, and so these have little granules in the cytoplasm that stains a really reddish color. These have a bilobed nucleus. These are actually lysosome-like, and they will digest parasitic worms. So if the body detects some parasitic worms, it will likely increase its production of the eosinophil. They're also released during allergic responses. So if you have a high eosinophil count, it could be an allergic response as well, if there's really no likelihood that that person has parasitic worms. Basophils are really rare. The nucleus stains a deep purple. There's going to be large purplish black granules. Basophil means this is a stain that actually it likes alkali or base. But anyway, this basophil is named because of these large purplish black granules. They stain a purplish black color. They actually contain histamine. The granules do. So histamine is an inflammatory chemical that will cause arterioles to dilate, open up. It causes capillaries to become more permeable. And so that's also the function of mast cells. And I referred to this somewhat in chapter 21 when we talked about the immune system. During inflammation, histamine is the chemical that will amplify that inflammatory response. And these are the pictures. Here's a leukocyte, the first granulocyte, the neutrophil. This has a multilobed nucleus, pale red and blue cytoplasmic granules, but it really has this obvious, really unusually shaped nucleus. Multi-lobed, that means a lot of lobes. An eosinophil, it actually has this bilobed nucleus. The most obvious thing on the eosinophil, though, would be these really reddish staining granules throughout the whole cell. Then you've got a basophil. It's also bilobed nucleus. You can barely see it, though, but the real dominant sign is these blackish purple granules that are, they pick up that stain to look a blackish purple color. Agranulocytes, they don't have the cytoplasmic granules. They are either the spherical or kidney-shaped nucleus. Of these agranulocytes, you've got lymphocytes. Lymphocytes are the second most numerous type of leukocyte. Remember, lymphocyte is different. Leukocyte means a general white blood cell. Lymphocyte is a specific kind of white blood cell. It actually has a large dark purple circular nucleus with a very thin rim of blue cytoplasm. We see these mostly in the lymphoid tissue, hence the lymphatic system, lymphocyte. So we'll see a lot of these in the lymph nodes and the spleen, and they look like little purple dots because most of that cell is filled up with this dark purple nucleus. They are crucial to immunity. If you'll remember, you had your T cells or T lymphocytes and then your B cells or B lymphocytes. So of these lymphocytes, you have the two major types crucial for your immunity. Remember that here's talking about the two types. T lymphocytes or T cells act against virus, infected, and tumor cells. This is your cellular mediated immune response. And then the B lymphocytes or B cells give rise to plasma cells that produce the antibodies. This branch is also called the antibody mediated or humorally mediated response. Monocytes, these are the largest leukocytes. They have a pale blue cytoplasm, and the nucleus is a dark purple U or kidney shape, or Pac-Man. Probably not many of you are old enough to remember Pac-Man, but that's what it reminds me of, and you'll see it in the picture. Monocytes actually leave the circulation, they enter the tissues and are stationed there as macrophages. They are actively phagocytic against viruses, etc. They also activate the lymphocytes. Here's a lymphocyte. This is very small. It's got the big purple nucleus in there. It kind of reminds me of a lunar eclipse or a solar eclipse. We actually have almost the whole sun eclipsed by the moon. Then you've got the monocyte. This is the one that has this kind of like a U-shaped nucleus, and I like to think of it as the Pac-Man with this mouth, because it also starts with M, like monocyte. Kidney-shaped nucleus, abundant, pale blue cytoplasm. And here is a diagram that represents leukocyte formation. Here's your hematopoietic stem cell or hemocytoblast, and there's actually several possible directions that this can go. If it goes to become a lymphoid stem cell, this is going to give rise to the B lymphocytes and then the T lymphocytes down this direction. Now, a myeloid stem cell will give rise to various types of cells that will, on the far left here, you have the developmental pathway that leads to the production of eosinophils. This one gives rise to basophils. And then over here, you've got your myeloblast that becomes a promyelocyte to become the neutrophil. And then there's also a monoblast that becomes a monocyte over this pathway. Just keep in mind, there's a quite complex developmental pathway, because with leukocytes, you need to have that ability to form the various types of white blood cells. Leukemias. This is a cancer of one of the types of white blood cells. It's fatal if untreated. Acute leukemia actually rises from the stem cells. Chronic leukemia occurs more often in older individuals. Leukemia is when cancerous leukocytes fill the red bone marrow. There are immature, non-functional white blood cells that are circulating. The individual can suffer internal hemorrhage and overwhelming infection because the cancerous leukocyte cells are filling up the red bone marrow, so it's taking away from the ability of the body to make red blood cells, and also these white blood cells are non-functioning, so that person can die from an overwhelming infection. Treatments would be irradiation, drugs, and stem cell transplants. Lymphomas is actually more specifically a cancer of the B or T lymphocytes. Typically, they will form in the lymph nodes, though not in the bone marrow. There's another type of cancer called multiple myeloma. This is cancer of the antibody-producing plasma B lymphocytes. Another type of blood disorder is infectious mononucleosis. It's highly contagious. It's a viral disease caused by Epstein-Barr virus. And this is actually indicated when you do a blood smear and you see atypical A granulocytes. The symptoms is they get very tired, and so the person just is very fatigued and can't seem to get enough sleep. This disease should run its course with enough rest. It's often associated with strep throat infection, with beta hemolytic streptococcal infection. Okay, now we're on platelets. This is the last topic of this chapter. But a platelet is actually a fragment of a megakaryocyte. This is the large cell that busts into pieces in order to form platelets. They stain they have blue-purple granules that stain quite readily. Platelets are essential for the clotting process. Normally, we have about 150 to 400,000 platelets per microliter. And platelets actually form a temporary platelet plug at the site of when a blood vessel is injured. Circulating platelets in the blood need to be kept inactive and mobile, otherwise you can get blockages in the circulatory system. Platelets actually age very quickly and degenerate in about 10 days, so the body has to continually replace them. The formation is regulated by thrombopoietin. If you remember before, I had up on the PowerPoint, platelets are also called thrombocytes. So a thrombus is another name for a clot. And the hormone thrombopoietin stimulates platelet production. And here's our developmental pathway, starting from the hematopoietic stem cell. The megakaryoblast is the first step, megakaryocyte, and this, you can see this huge mega means large nucleus. Megakaryocyte, and this will bust into little pieces, which now we call platelets. This is the summary of the formed elements of blood, starting with the erythrocytes, and you can look at this in your book. We've already talked about a lot of this. It's just a summary. Leukocytes are white blood cells, and the various types of granulocytes. There's 3 of them. And then we have our 2 types of agranulocytes here, and your platelets. Okay, the last topic dealing with platelets, related to platelets, is the process of hemostasis. Not homeostasis, but hemostasis. Hemo means blood, stasis means stop. So in order to stop the bleeding, we need clotting factors, we need clotting proteins, and also there are substances, chemicals actually, that are released by platelets and injured tissues, and all of these need to come together to stop the bleeding when necessary. There's 3 steps with hemostasis. Vascular spasm, that means the blood vessel begins to spasm, to kind of try to close. Then there's platelet plug formation, and that's when all the platelets come together and gather together at the site of the injury. Then the last step is called coagulation or clotting. In your Canvas module for the lecture exam, you will see an animation on blood clotting that's excellent, that goes through these 3 processes. And so I would suggest that you watch that at least a couple of times. It's only a few minutes long, but it really gives you the idea and shows it in a dynamic way what's happening. Okay, vascular spasm. This is vasoconstriction of the damaged blood vessel. This will be triggered by direct injury, and then there'll be chemicals actually released by the endothelial cells. These are the cells lining the blood vessel, and the platelets. And it'll be triggered by these chemicals, direct injury, and pain. The next step is platelet plug formation. This is considered one of the few positive feedback cycles in the body. This is when the damaged endothelium, it actually has collagen fibers, and they become kind of sticky. And the platelets will then stick to these collagen fibers. The platelets swell up and they become spiky and sticky, and they will now release chemical messengers. One of those messengers is ADP. Believe it or not, adenosine diphosphate is used in more than one way in the body, and this chemical here will cause platelets to get sticky, to stick together and release their contents. Another chemical you may have heard of as a neurotransmitter, serotonin. Locally, serotonin will lead to vascular spasm, will increase that vascular spasm, and platelet aggregation. This is when the platelets get together, they crowd together. The third step is called coagulation. Coagulation is going to reinforce that platelet plug with the protein called fibrin. This is going to cause the blood to go from a liquid into a gel. There's a lot of reactions. There's a series of reactions with many different types of clotting factors. You're not going to have to learn every single detail. There's actually clotting factor number 1 all the way up to number 13. Most of these clotting factors are plasma proteins. Vitamin K is a vitamin that we don't normally talk about in nutrition class, although you may, if you've taken nutrition, your instructor might talk about it. Vitamin K is necessary for blood clotting because it's needed in order to synthesize 4 of these clotting factors. Vitamin K is very high in green leafy vegetables. And if you've ever heard of warfarin, that's the blood thinner that's given to people to prevent clotting inside of their body. That actually is inhibits vitamin K activity. That's why it decreases their ability to form clots. And these are the events. Okay, vascular spasm is when the smooth muscle contracts, causing vasoconstriction. There's the injury right here. 2, the platelet plug is formed because the injury to the lining of the vessel exposes collagen fibers and the platelets stick to them. The platelets are now releasing chemicals that make nearby platelets sticky and a platelet plug forms. And here's step 3, coagulation. A fibrin formed, that protein fibrin is insoluble. It forms a mesh that traps the red blood cells in the platelets, forming the clot. Now there's actually a lot of steps, but I want to kind of give a little summary here. One of the molecules that is involved is called a prothrombin activator that's formed. There is a soluble or inactive molecule that's present in the blood called prothrombin. It will be converted into thrombin by the prothrombin activator. Thrombin will now catalyze turning fibrinogen, which is a soluble protein ever present in the blood. It will now be turned into fibrin. Fibrin, think of a fiber. This is insoluble and it will actually twist itself up in that platelet plug and squeeze out the water to form the clot. You really do not want to have fibrin traveling around in the bloodstream as fibrin because it's an actual insoluble fiber and it can lead to blockages. So it's a soluble protein here. Thrombin will turn the fibrinogen into fibrin. Fibrin strands form the structural basis for the clot. And fibrin will actually now turn that plasma into a gel-like trap. And the thrombin will also activate factor 13. Factor 13 will cause cross-linking with the fibrin to strengthen and stabilize the clot. And as you can see, there's an intrinsic and extrinsic pathway. Intrinsic would be like right at the site within this area. Extrinsic would be outside of that where there's tissue factor involved, etc. But here you can see all these factors, clotting factors that are involved. But finally, once you get that, now you've got these clotting factors that are going to lead to this molecule right here, which is called a prothrombin activator. The prothrombin will be turned into thrombin. Thrombin will now cause fibrinogen, which is soluble, to be turned into fibrin, which is insoluble. And then they're showing how that clotting factor 13 will cross-link with this fibrin mesh to make a very strong clot. It actually traps red blood cells, which is why on the outside of the body you can see it, and we call it a scab. And this is showing photographic evidence, an electron photomicrograph. with red blood cells all trapped in this mesh. There's also clot retraction. There's actin and myosin. Remember actin and myosin in skeletal muscles? Well, these proteins are present here in the platelets, and they contract, and these fibrin strands squeeze out the serum. It draws that ruptured blood vessel together. The vessel will heal as the clot retraction occurs. So eventually, when the tissue is healing, this clot will retract. There's also another process called fibrinolysis, and this is when the clot it can't get too big. It needs to be removed after the healing occurs. You don't want an excess clot floating around in the bloodstream. There is a molecule, a protein called plasminogen. It'll be turned into plasmin. Plasmin is actually a fibrin digesting enzyme. Some of the disorders of hemostasis, thromboembolic. This is when a thrombus becomes an embolus. An embolism is something floating in the bloodstream, and a thromboembolism is a clot floating around in your bloodstream. So if it breaks off at the site of a larger artery, for example, and travels downstream to smaller arteries or arterioles, it can just completely block that vessel. So a thromboembolus in the bloodstream is dangerous. There's also a bleeding disorder where the person is not able to form clots and can bleed to death. And then there's another disorder called disseminated intravascular coagulation, abbreviated DIC, that involves both. Okay, so a thromboembolus. Here it is. The thrombus is a clot that develops and persists in an unbroken blood vessel. Thromboembolus is when the thrombus is freely floating in the blood. Thromboembolism. The thromboembolus is now obstructing a vessel. Risk factors for this would be someone who's got atrial fibrillation. That's probably one of the more common causes, because in the atria of the heart, these are the upper chambers, as they contract, or they actually have little areas in there where blood can collect. There's little, if you remember on the heart, and unfortunately we haven't gotten there yet, but it'll make more sense when we do. The atria have auricles. They're like little flaps, and within there's areas where they can expand. And so if little blood clots form in the atria, because the atria are not contracting fully, a clot can form, and then it can be sent out to the ventricles and then out into the body and cause blockage of a blood vessel. Arterial sclerosis is another risk factor. Someone who's got chronic high blood pressure or diabetes mellitus, these can lead to blood vessel disorders that can increase the risk for thromboembolism. The way they're treated is aspirin. If you ever heard that someone is having a heart attack, air quotes, heart attack, that's actually a myocardial infarction. The myocardium is the heart muscle, and it has its own circulation of actually blood vessels that serve the heart muscle. Okay, and these, if they're tiny, they come right off of the aorta, and if there's a blockage there, it can lead to what we call a heart attack. So one of the first things, if you suspect someone that's having a heart attack, if they're having chest pain, for example, they can take even a baby aspirin, and that will decrease the chances of any clot that may be there from growing, because aspirin inhibits platelet aggregation. Heparin is another blood thinner that can be used to decrease coagulation. Warfarin is actually the drug that I just talked about. It's also called Coumadin, but that will decrease clotting. And there's also another new one called dabigatran, which inhibits thrombin formation. Bleeding disorders include thrombocytopenia. That's when there's too few of platelets produced. It's evidenced by petechiae, little red bruising or red dots under the skin. And these would be due to spontaneous, widespread hemorrhage because the individual doesn't have enough platelets. This is typically when platelets are less than 50,000 per microliter. Treatment would be platelet transfusion. Also, if somebody has impaired liver functions, they cannot synthesize the procoagulants. So the liver is responsible for making the clotting factors. So if your liver is not working, it won't be able to make them. Also, vitamin K deficiency, hepatitis, and cirrhosis. Liver disease, actually you get decreased bile production, impairing the fat and vitamin K absorption. So if somebody has impaired liver function, they will also be experiencing vitamin K deficiency. Another type of bleeding disorder would be hemophilia. There's several types: hemophilia A, hemophilia B, and hemophilia C. And they have learned that hemophilia A is when clotting factor 8 is too low. That's the most common type of hemophilia. Hemophilia B is when clotting factor 9 is too low, and hemophilia C is factor 11 is not produced enough. And this is a genetically inherited disorder. All of them are. Symptoms of hemophilia would be prolonged bleeding. It's not a very rapid hemorrhage, but even a slow bleeding. And you can imagine in the head and within the cranium, if there's even a very slow bleed that's beginning to build up within the cranial cavity, it can cause brain damage. So it can be very dangerous. Also, the bleeding, eventually that person can bleed out or obviously it will become anemic. Treatment. It used to be that they would take blood donations and pool many blood donations together to obtain that factor that is missing from many individuals. Back in the 1980s and early 1990s, they didn't understand a lot about HIV infection. They were just learning about that with HIV and AIDS. And so almost every child who had hemophilia ended up to be HIV positive because they were obtaining the factor from a huge pool of donors, and they didn't have the proper testing for HIV back then. Now we have the testing, but also the factor can be produced genetically, so there's no risk of passing an infection in the blood by giving this distributing factor or infusing factor to that individual. DIC, widespread clotting, causes bleeding. The clotting will block the blood vessels, and then you have severe bleeding because the residual blood doesn't have any more of the clotting factor. So you've got both clotting and bleeding going on. This happens, sometimes it's one of the risk factors during pregnancy and definitely during blood transfusions. Blood transfusions. They learned this many, many years ago when a woman, when she was giving birth, one of the main risk factors for the mother during birth is hemorrhage. And so at that time, the husband would want to help her she would be losing too much blood, so the idea was, I'll give you some of my blood. And they actually had some cannulas that they can, take the blood from one person and inject it into the other person. So he would, subject himself to the physician who could take his blood and infuse it into the woman. Sometimes it saved her life, but other times that transfusion led to her death. They also tried this on the battleground as well, and so eventually they learned that certain individuals have compatible blood, others do not. And if it's incompatible and you're getting a blood transfusion, it can be fatal. That's because there's about 30 different kinds of glycoprotein antigens on our red blood cells. If the body detects a foreign one, it will initiate the immune response. The antigens that promote agglutination are called agglutinogens. And so this is going to cause the blood to agglutinate. The blood cells clump together and are no longer able to function. The antigens of the ABO blood groups and the RH blood groups will cause vigorous transfusion reactions. We are going to be talking about blood transfusion and the transfusion reactions in lab, but I'm going to kind of swiftly go through this right now. Here you can see the various ABO blood groups. Some people are type A, B, other people are type B, other people have type A, and other people have type O. When we refer to these blood groups, that means that your red blood cells have certain markers, which they designate A or B. Some people have both, like this one has a type A marker, antigen, and it has a type B marker. Those are the people with AB blood type. A person with type B, they actually have only the B markers, all right? Other people are type A and they have only the A markers, which are like these little spikes. People who are type O, it's like a 0. They do not have A markers or B markers. So they're showing here also the anti-A. So if you have type B and you receive blood that has the A markers, your body's going to make antibodies to it. So we'll look at this actually a little bit more during lab when we have more time. And then there's the RH factor. So I kind of think of the ABO blood groups. These are markers. There's either type A or type B, or a person can have both, or they have neither one, and they would be type O. Then there's the RH factor, and this would be a different style of marker. Either you have it or you don't. If you're Rh positive, you have the marker. If you're Rh negative, you do not. Rh comes from the word rhesus monkeys. That's where they first discovered this. That's why they call it the Rh factor. If a woman does not have the Rh marker on her red blood cells, and she's carrying an Rh positive fetus, her body may generate an immune response if there's any mixing of blood. And so what happens, and this typically is not for the first pregnancy, but let's just say she is carrying an Rh positive fetus, and this Rh factor is actually a dominant, so 3 out of 4 children will have it. Well, actually, if a male is, if the dad is Rh positive, chances are his child is going to carry it. But actually, with the Rh negative mom, she has the 2 negative genes. But anyway, we'll talk more about the genetics of it in lab. But let's just say an Rh negative mom is carrying an Rh positive fetus. If there's any mixing of the baby's blood into her bloodstream, her immune system will begin to make antibodies against the Rh positive blood cells. Then the most dangerous time is with the second pregnancy, and then so the mother already has this immune response developed against the Rh positive marker, and then the mother's immune factors can get into the baby's bloodstream and begin to completely destroy the baby's red blood cells. This is called erythroblastosis fetalis. The Rh negative mom is exposed to the Rh positive blood of the fetus during the delivery of the first baby. So another type of problem would be with a transfusion reaction, and you get mixed matched blood that's infused. A donor's blood cells could be attacked. The symptoms would be fever, chills, low blood pressure, rapid heartbeat, nausea, and vomiting. The treatment would be, and you have to treat it to prevent kidney damage, because the hemoglobin can actually damage, come out of solution, damage the tiny kidney structures. So you have to increase the fluids and the diuretics to wash out the hemoglobin. So what happens is that the recipient's plasma agglutinins are attacked. Type O is universal donor. Type AB is a universal recipient, which is kind of an oversimplification because there's other kinds of oversimplification, it's misspelled. There's other markers too on blood, so anytime somebody gets a transfusion, you have to type and cross-match that blood, or they actually mix a little bit to see if the blood is compatible. Whoops. An autologous transfusion is the best, so if somebody knows they're going to go through a surgery where they're going to be potentially losing a lot of blood, they can pre-donate their own blood, and a period of time later their body's able to replace all those blood cells, and then they can receive their own blood. That's called an autologous transfusion, where there's no chance of rejection. This is showing you, this is actually what we're going to be doing in lab, where you're going to be testing your blood serum. I'm just going to kind of skip through this right now because we will be doing the blood testing in lab, and I believe you'll get quite a better understanding of that. This would be showing you type AB blood. If a person is type AB blood, if you put they're type AB, so if you put type A or anti-A anti-sera on the blood cells clump, and also anti-B sera will clump these cells. Type A indicates this person is a type A. When you put the anti-A, these will clump. But if you put anti-B, it won't clump because this person is type A. And just the opposite with type B. If you put the anti-sera on for type A, nothing happens because this person has only the B markers. And you put anti-B, you will see clumping. If a person is type O, they do not have A nor B, so you put the anti-A sera on, nothing happens. You put the anti-B, nothing happens. So here is evidence of no clumping. You can see no clumping here. This is clumping, where you see little granular looking things. Clumping, clumping, and clumping. Diagnostic blood tests, you may have heard of these before. Hematocrit, blood glucose, microscopic examination, differential white blood count, which I talked about before. The different kinds of white blood cells are counted. They also would want to see prothrombin time and platelet counts if someone's having potentially a bleeding problem. And it also can figure out the functioning of your liver and your kidneys by doing the blood chemistry. It can indicate liver or kidney disorders. Complete blood count is abbreviated CBC. And that's the end. Have a wonderful day. I will see you next time.